Welcome back to the deep dive. Today, we're tackling a really big one, diabetes mellitus. We've got this incredible stack of sources you sent, articles, notes, research pushing us way beyond just the basics.
Yeah, it's a topic that demands attention, doesn't it? Diabetes management is intense. I mean, not just the day-to-day grind, but the sheer range of risks. We're talking immediate life-threatening crises right through to damage that builds up over decades.
Exactly. So our mission today isn't just defining type 1 or type 2. We want to distill the really high-impact stuff you need. The clinical distinctions that are critical in an emergency, some surprising physiological risks like with exercise in type 1, and the strategies to actually halt that chronic damage.
It's about maximizing safety and really thinking about long-term health.
Right. How do we keep people safe and well?
And fundamentally, whether we're talking type 1, type 2, whatever, it all comes back to insulin. It's either that's type 1, an absolute deficiency, or the body's resisting it, or not making quite enough the relative deficiency we see in type 2.
And that difference drives everything else.
Everything. Complications, treatment choices, all of it. So we'll focus on, let's say, 3 core areas. First, those immediate emergencies, DKA and HHS. Huge difference there. Second, the sort of day-to-day realities of living with type 1, especially exercise and some of the psychological hurdles.
Okay.
And finally, the long game. Preventing that microvascular damage, kidneys, nerves, and the bigger cardiovascular picture.
Got it. Okay, let's dive right into the deep end then, the acute crises. DKA and HHS both involve crazy high blood sugar, right?
Yeah.
But you're saying they're fundamentally different beasts. Let's start with DKA.
Diabetic ketoacidosis, DKA. Yeah, this is the classic emergency, mostly in type 1 diabetes. And it stems directly from that absolute lack of insulin. No insulin means cells can't get glucose for energy.
So they're starving, effectively.
Starving. So the body hits the panic button and starts breaking down fat stores like there's no tomorrow, massive lipolysis.
Okay, breaking down fat.
Mm-hmm.
What does that produce?
A flood of free fatty acids hits the liver. The liver tries to turn these into energy, but the process churns out ketone bodies acetoacetate, and the one we measure more often, beta-hydroxybutyrate.
Ketones. And they're acidic, hence the acidosis in DKA.
Exactly. Strong acids. They build up fast, and the blood becomes dangerously acidic. That's the metabolic acidosis, high anion gap acidosis specifically. Clinically, you see someone who's incredibly dehydrated, all that sugar, pulling water out, and glucose levels typically maybe 300 to 800 milli-GDL.
And the body tries to fight back against that acid.
Right.
The breathing changes.
Oh, yeah, it's a desperate measure because small respirations, you see this deep, rapid, almost gasping breathing. The lungs are working overtime trying to blow off carbon dioxide.
Because CO2 acts like an acid in the blood.
Right. So hyperventilating is the body's way to try and lessen the acid load to compensate for the metabolic storm that's happening.
Okay, clinical pearl time. There's one symptom here that can really throw clinicians off track in the ER, isn't there?
Yes, absolutely critical to remember this. You get a young person, maybe newly diagnosed, type 1, classic polyuria, polydipsia, weight loss, and severe abdominal pain.
Abdominal pain. Why is that such a red herring sometimes?
Because it can mimic a surgical abdomen, appendicitis, something like that. But often in DKA, the pain is actually from the metabolic acidosis itself, maybe irritating the gut lining or causing stasis. The danger is getting sidetracked, ordering loads of scans, delaying the DKA treatment.
So the first step is?
Finger stick glucose.
Right away.
If it's high, then check labs. You're looking for that low bicarbonate, say under 18, positive serum ketones, and the high anion gap. Treat the DKA, and usually that belly pain just melts away as the acidosis corrects.
Okay, so that's DKA, absolute insulin lack, ketones, acidosis. Now, HHS, hyperosmolar hyperglycemic state. This is more the type 2 picture, often in older adults.
That's right. HHS is about relative insulin deficiency. There's just enough insulin floating around to stop that massive fat breakdown to suppress ketogenesis.
So no ketones, no acidosis.
Minimal ketones, usually no significant acidosis, so you don't typically see the Usmle breathing. But the lack of insulin is still profound enough to let the blood sugar run absolutely wild.
So the danger here isn't acid, it's something else.
It's extreme runaway hyperglycemia. We're talking glucose levels often way higher than DKA, frequently over 600, sometimes even north of 1,000 milli-GDL.
Wow. And that much sugar in the blood must pull out enormous amounts of water.
Exactly. Intense osmotic diuresis. The patient loses massive volumes of water into the urine. We're talking profound dehydration.
How much fluid loss are we talking?
It can be staggering. 8-10 liters of total body water deficit, often developing more slowly, maybe over days or weeks, compared to the faster onset of DKA. And the key clinical feature, the thing that really screams HHS, is the altered mental status.
Confusion, lethargy.
Confusion, profound lethargy, even coma. And this isn't from acidosis, remember. It's directly linked to the blood just being incredibly concentrated.
The hyperosmolarity.
That's the ticket. Serum osmolality shoots up, usually over 320 millisem/kJ. That extreme concentration literally shrinks brain cells, causing the neurological symptoms. So labs, sky-high glucose, minimal ketones, normal pH and bicarb, but crucially, that elevated serum osmolality.
And triggers for HHS. Infection, not taking meds.
Mhm.
Anything else specific we should flag?
Yeah, besides the usual suspects like infections or stopping meds, you absolutely have to be aware of certain drugs. Some atypical antipsychotics like olanzapine are well-known culprits. They can worsen insulin resistance or impair secretion.
So if you see someone on olanzapine with really high sugar and confusion.
HHS should be right at the top of your differential diagnosis. Big red flag.
Okay, two distinct crises, DKA and HHS. But the very first step in managing both is identical and maybe counterintuitive. You mentioned fluids first.
Absolutely non-negotiable. Fluids, fluids, fluids. Aggressive IV fluids, usually normal saline right out of the gate for both DKA and HHS before you even think about starting insulin.
Why is that sequence so critical?
Well, first, you've got profound volume depletion in both conditions. Fluids restore circulation, stabilize blood pressure. Second, and this is key, rehydrating actually improves tissue perfusion and helps the insulin work better when you do give it. It corrects that hyperconcentration.
Right. Now let's get to the tricky part you flagged, potassium. The potassium paradox. Why is this so dangerous?
This is where things can go wrong quickly if you're not careful. Here's the paradox. Both DKA and HHS patients have lost a ton of potassium in their urine because of that osmotic diuresis. They have a significant total body potassium deficit.
Okay, their bodies are low on potassium overall.
But when you check their initial blood test, the serum potassium level might look normal, or confusingly, it might even be high.
How can it be normal or high if the total body stores are low?
It's physiology playing tricks. In DKA, the acidosis, all those hydrogen ions, drives potassium out of the cells into the bloodstream in exchange for hydrogen ions moving in. And in both DKA and HHS, the lack of insulin means the normal mechanism pushing potassium into cells isn't working.
So potassium is stuck outside the cells, making the blood level look artificially inflated.
Exactly. It masks the true underlying total body deficit.
And the danger kicks in when we start the insulin.
Precisely. Insulin's main jobs include driving glucose and potassium into cells. As soon as that IV insulin hits the bloodstream, it powerfully shoves potassium back into the cells. If you haven't started replacing potassium first, and the level was already borderline or artificially normal,
The serum level plummets.
leading to severe, potentially fatal hypokalemia.
And what does severe hypokalemia do?
Cardiac arrhythmias. We're talking dangerous ventricular rhythms, cardiac arrest. It's a true medical emergency. So the absolute rule, the safety net, is this. You must check the potassium level before starting insulin. If it's less than 5.3 MEQL, you need to start IV potassium replacement before or at the same time as the insulin infusion.
Don't chase the sugar down without protecting the heart from low potassium.
Couldn't have said it better myself. Protect the heart first.
Okay, so we've got fluids running, potassium managed carefully, insulin infusion started. The glucose will start dropping, especially in DKA. But you said stopping the insulin drip too soon is a mistake. How do we know when DKA is actually resolved?
Yeah, this is a common pitfall. The glucose comes down relatively quickly with insulin and fluids. But just because the sugar looks better doesn't mean the underlying metabolic problem, the acidosis, is fixed.
And you can't rely on urine ketones either.
Nope. Urine ketones can stay positive for days after the actual ketoacidosis has resolved. That's because the main ketone, beta-hydroxybutyrate, gets converted back to acetoacetate as the patient recovers. And acetoacetate is what the urine dipstick primarily detects. So urine ketones lag behind.
So if not glucose and not urine ketones, what's the definitive marker?
The serum anion gap. Remember, the high anion gap is caused by those unmeasured ketoacid anions floating around. As the insulin works and the body starts metabolizing those ketones properly, the bicarbonate level rises and the anion gap closes, returning to normal, usually below 12 NEQL.
That's the green light.
Yeah.
An F gap closed means the metabolic fire is out.
That's your target. Once the gap is closed, the acidosis is resolved, and the patient is stable and able to eat, then you can safely transition them from the continuous IV insulin drip to subcutaneous insulin, usually a basal bolus regimen.
And if you stop the drip before that gap closes,
You risk rebound DKA. The ketones come right back. You have to bridge that transition carefully.
okay, that covers the acute emergencies. Let's shift gears now to living with type 1 day to day. Exercise is obviously encouraged for health, but for someone with T1DM, it introduces this real paradox, doesn't it?
It absolutely does. It highlights how T1DM overrides the body's normal, elegant feedback loops. In someone without diabetes, when you exercise, your muscles soak up glucose, right? But your pancreas cleverly dials back insulin secretion to prevent your blood sugar from crashing.
Makes sense. Keeps things balanced.
But in T1DM, the insulin isn't coming from the pancreas. It's coming from an injection or a pump. It's exogenous, and it doesn't automatically decrease just because you started running.
So the insulin keeps working, driving glucose into cells, while the muscles are also pulling glucose out faster because of the exercise.
Exactly. And exercise can even speed up the absorption of injected insulin from the subcutaneous tissue. So you've got this double whammy effect, pushing glucose down. That puts the person at a much higher risk of exercise-induced hypoglycemia.
Especially during longer or more intense activity.
Definitely. Endurance stuff is particularly risky.
So how do people with type 1 manage this? They can't just avoid exercise.
No, and they shouldn't. It requires planning and adjustment. It's a combination of reducing insulin and increasing carbs. For instance, if you're planning exercise within, say, 3 hours of eating, you typically need to reduce your pre-meal rapid-acting bolus insulin dose for that meal.
Okay, and for longer workouts, like training for a race.
For prolonged activity, like maybe 90 minutes or more, you often need to reduce your background or basal insulin rate, maybe by 20%, maybe even 50% during the activity, and sometimes for hours afterwards too, because the sensitivity to insulin can remain high.
And fuel. You mentioned carbs.
Yeah, you usually need to proactively consume extra carbohydrates before, during, and sometimes after exercise. Maybe 15 to 30 grams of fast-acting carbs every 30 to 60 minutes during sustained activity, depending on how intense it is. It's a constant balancing act.
But one thing you absolutely don't do is stop the basal insulin completely, right? Even for exercise.
Never. That's the cardinal sin in T1DM. Remember, people with type 1 make zero insulin. Stopping their basal insulin, even for a few hours, guarantees they'll start breaking down fat and heading towards DKA. Reduce it, yes. Stop it, absolutely not.
Got it. Okay, sticking with hypoglycemia risk. Let's talk about hypoglycemia unawareness, HAF. Sounds terrifying.
It is. Hypoglycemia-associated autonomic failure, or HAF. It tends to develop after many years of type 1, especially if someone has had repeated episodes of severe low blood sugar. The body's warning system just kind of wears out.
What exactly breaks down? What's the physiology?
Two key things fail. First, the alpha cells in the pancreas often stop responding properly, so you don't get that protective glucagon surge that tells the liver to release sugar. Second, and this is crucial for awareness, the sympathetic nervous system response gets blunted.
The adrenaline response.
Exactly. Normally, when your sugar drops, you release epinephrine adrenaline. That causes the warning symptoms. The shaking, the sweating, the pounding heart, the anxiety. That's your body screaming, "Feed me!"
But with HAF, those warning signs just don't happen.
They diminish or disappear entirely. The person doesn't feel the low coming on. They go straight from feeling okay to suddenly experiencing neuroglycopenia, the brain not getting enough glucose.
What does that look like?
Severe confusion, slurred speech, inability to concentrate, bizarre behavior, potentially seizures or loss of consciousness. They only realize something's wrong when it's already critically dangerous or someone else notices.
That's incredibly risky. How do you even manage that?
It's tough. The main strategy is meticulous, rigorous avoidance of any hypoglycemia for a period of time. You have to try and retrain the body, let those counter-regulatory systems recover.
So you might actually aim for slightly higher blood sugars temporarily.
Yes, counterintuitively. You might relax the A1C target a bit, maybe aiming for 7.5% instead of striving for below 7%, just to create a safety buffer and give the adrenergic response a chance to reset. It prioritizes immediate safety over perfect long-term numbers for a while.
Wow. And that fear of lows, especially after a severe one, can lead to behavioral changes too, can't it?
Oh, absolutely. This feeds right into what we call behavioral hypoglycemia avoidance. Imagine having a seizure from low blood sugar. or needing someone else to give you an emergency glucagon injection. That's deeply frightening, traumatic even.
Understandably. So people react to that fear.
They do. They develop this intense fear of it happening again. And to prevent it, they often start, consciously or subconsciously, running their blood sugars higher. They might skimp on their insulin doses, especially mealtime ones, or snack more frequently than needed.
They're trying to create a safety margin out of fear.
Exactly. But the clinical result is often poor overall control. You might see decent fasting numbers because those are often easier to manage, but their HbA1c stays stubbornly high. Those post-meal spikes are raging, or their sugars are just generally elevated all day.
So they avoid the scary lows, but at the cost of long-term high sugar exposure.
Right, which increases the risk of all those chronic complications down the line.
So as a clinician, how do you address that? It's not just about telling them to take more insulin.
No, you have to approach it with empathy. You need to ask directly, tell me about your worst low blood sugar experience. Acknowledge the fear. Then you work with them. Maybe adjust the insulin regimen to be more flexible. Perhaps accept a slightly less aggressive A1C target for a while, like we discussed with HA. And crucially, ensure they have glucagon kits and know how to use them. Giving them a safety net can reduce the fear.
It's about empowering them, not just dictating numbers.
Precisely. Addressing the fear is as important as adjusting the dose.
Okay, let's pivot now to those long-term complications, the chronic damage, starting with the diabetic kidney disease, DKD.
DKD, yeah, a huge issue. It's the leading cause of end-stage renal disease, basically. Years and years of high glucose damages the tiny blood vessels, the glomeruli in the kidneys. It's often silent for a long time.
So screening is key. When do we start looking for it?
For type 2 diabetes, you start screening right at diagnosis with a urine test, the urine albumin to creatinine ratio, UACR. Check it annually. For type 1, the damage usually takes longer to develop, so we typically start screening about 5 years after diagnosis.
And if you see diabetic eye disease, like proliferative retinopathy,
that's a very strong clue. Significant eye disease strongly suggests similar microvascular damage is happening in the kidneys too, making DKD highly likely.
Now, here's a point you emphasized earlier that seems crucial for prevention. What's the single most effective thing we can do to slow down DKD progression? More important than just glucose control.
Intensive blood pressure control. This cannot be overstated. Getting that blood pressure down, ideally below 130/80 mmHg, has a more powerful protective effect on slowing the decline in kidney function than even super tight glucose control alone.
Really? Why is BP control so impactful here?
Well, high blood pressure damages kidney vessels directly, but in diabetes, there's also increased pressure within the glomerulus itself, the kidney's filter. This intraglomerular hypertension accelerates the damage.
And certain BP meds are better than others.
Yes. ACE inhibitors, or ARBs, angiotensin receptor blockers, are the preferred agents. They're first line.
Why them specifically?
Because they do double duty. They lower systemic blood pressure, obviously, but they also preferentially relax the efferent arteriole, the small artery leaving the glomerulus. This specifically lowers that damaging pressure inside the filter. It's direct kidney protection.
Got it. So BP control with an AAEE or ARB is paramount for kidney health and diabetes.
Absolutely. And now we also have the SGLT2 inhibitors showing major renal benefits in T2DM, but strict BP control remains foundational.
Okay, moving from kidneys to nerves. Diabetic peripheral neuropathy. This follows a specific pattern, right?
It does. It's typically length dependent, meaning the longest nerves get damaged first. So symptoms usually start in the toes and feet and gradually move up the legs and later maybe affect the hands, the classic stocking glove pattern.
And the symptoms depend on which type of nerve fiber is affected.
Right. We talk about large fibers and small fibers. Large myelinated fibers handle things like vibration sense, proprioception, knowing where your limbs are in space, and reflexes.
The damage there causes
Numbness, tingling, loss of balance, especially noticeable when you close your eyes, difficulty walking, and often loss of the ankle reflexes early on.
and the small fibers.
The small, unmyelinated fibers transmit pain and temperature signals. Damage here causes the painful diabetic neuropathy, that awful burning, stabbing, shooting pain, often worse at night, pins and needles. Really debilitating.
So how do we treat that neuropathic pain? And it's not like treating inflammatory pain, is it?
No, standard painkillers like ibuprofen often don't touch it. We need drugs that target the nerve signaling itself. First-line agents are usually anticonvulsants like pregabalin or gabapentin.
Or certain antidepressants?
Yes, the SNRIs, serotonin norepinephrine reuptake inhibitors like duloxetine or venlafaxine are also excellent first-line choices. They modulate pain pathways in the central nervous system.
What about older drugs like amitriptyline, tricyclics?
Amitriptyline works, but we tend to avoid it now, especially in older patients or those with heart issues. Tricyclics come with a lot of baggage, anticholinergic side effects like dry mouth, constipation, confusion, urinary retention. Plus, cardiac risks, they can affect heart rhythm, cause orthostatic hypotension.
There's already a risk with autonomic neuropathy from diabetes.
Exactly. So pregabalin, gabapentin, or an SNRI are generally much safer choices for most patients.
Okay, and that nerve damage, the neuropathy, leads directly to another major complication: foot ulcers.
The diabetic foot ulcer. It's the main reason for diabetes-related amputations. And the terrible irony is that the initial injury is usually painless.
Because of the neuropathy loss of sensation.
Precisely. Loss of protective sensation. Someone might have a stone in their shoe or wear ill-fitting shoes or step on something sharp, and they just don't feel it. Repeated minor trauma goes unnoticed. Ulcers form typically under pressure points like the ball of the foot or heel.
And they can get infected easily.
Very easily, often leading to deep infections, osteomyelitis, bone infection, and ultimately amputation if not caught and managed aggressively. Neuropathy also contributes to foot deformities like Charcot foot, which further increases ulcer risk.
So if patients can't feel their feet properly, how do we screen for this risk? How do we identify who needs extra care?
The key screening tool is the 10-gram monofilament test. It's simple, quick, done in the clinic. You use a standardized nylon filament and touch it to specific points on the bottom of the foot.
And if they can't feel it?
If they can't feel that 10-gram pressure, they've lost protective sensation, they are at high risk for ulceration. That means mandatory daily self-foot checks, proper footwear, regular podiatry visits. It's a critical preventative measure.
And sometimes that foot ulcer is actually the first sign that someone even has diabetes, isn't it?
Sadly, yes. We often see overweight adults present with a non-healing, painless foot ulcer. You do the workup, check an A1C, and discover they've likely had undiagnosed type 2 diabetes silently damaging their nerves for years. It's a stark reminder of how insidious T2DM can be.
Right. Okay, let's move into tailoring type 2 management more specifically.
Yeah.
The drug options have exploded, which is great, but makes choices complex. Let's start with a common problem: post-meal sugar spikes.
Postprandial hyperglycemia. Yeah, you see this pattern. Someone's taking their metformin, maybe even a basal insulin. Their fasting glucose levels look pretty good, maybe in the 120 range.
Okay.
But their overall HbA1c is still high, maybe 8% or 8.5%. It doesn't quite add up.
So good fasting, high A1C, what does that tell you?
It tells you the problem is happening after meals. Their body just can't handle the carbohydrate load effectively. The insulin response is too slow or too weak, leading to big glucose spikes a couple of hours after eating. The fasting control is okay, but the post-meal control is shot.
So how do you target those mealtime spikes specifically?
You need to add a rapid-acting or prandial insulin, something like Lispro, Aspart, or glulicine, taken just before meals. This insulin kicks in quickly and peaks around the time the glucose from the meal is hitting the bloodstream, helping to cover that load.
So you'd continue their basal insulin or metformin for the background control?
Yes, you usually continue the basal insulin or other background meds, but you add the prandial insulin specifically to manage those post-meal excursions and bring the overall A1C down.
Okay, that makes sense. Now, about A1C targets themselves. We used to think lower is always better, pushing for really tight control. But major studies like UKPDS and especially Accord changed that view, didn't they?
They really did. It was a crucial reality check. We learned that intensive glucose lowering, driving the A1C way down, say below 6.5% or even 6%, definitely provides benefits. But those benefits are mostly in reducing microvascular complications.
So less risk of eye disease, retinopathy, and kidney disease, nephropathy.
Yeah, exactly. Significant reductions there. But the Accord trial delivered a shock.
What was the shock?
The group randomized to the super strict A1C target, below 6.0%, actually had higher overall mortality. More people died in the intensive control group.
Why?
It was largely attributed to a significant increase in severe hypoglycemic events. Trying to keep the sugar that low day in and day out inevitably leads to more dangerous lows. And those severe lows can be fatal, especially in people with underlying cardiovascular disease.
So chasing ultra-low A1C numbers didn't actually reduce heart attacks or strokes or overall death rates and might even increase risk.
In that high-risk population studied in Accord, yes. It showed us there's a point of diminishing returns and even potential harm from overly aggressive glucose lowering in many patients.
So what's the general A1C target now for most adults with T2DM who aren't elderly or frail?
For most typical non-elderly patients, the target is generally around 7%. That seems to be the sweet spot balancing the microvascular benefits with minimizing the risk of severe hypoglycemia. We might aim for tighter control, like 6.5% in younger, healthier patients with newly diagnosed diabetes and low risk of lows, but 7% is a good standard target for many.
Okay, balancing risks and benefits. Now let's talk about the newer drug classes, especially for patients who have T2DM and other major issues like heart disease or obesity.
hmm
Metformin is still first line, but what comes next if they have, say, established cardiovascular disease, ASCVD?
This is where treatment has really transformed. If you have T2DM and known ASCVD, like a history of heart attack, stroke, peripheral artery disease, simply lowering sugar isn't enough. The guidelines now strongly recommend adding an agent with proven cardiovascular benefit, regardless of the starting A1C.
And the two main classes here are.
GLP-1 receptor agonists and SGLT2 inhibitors.
Let's take GLP-1s first. Liraglutide, semaglutide. How do they work?
They mimic a natural gut hormone, GLP-1. This hormone does several things. It boosts insulin secretion, but only when glucose is high, so low hypoglycemia risk on their own. It suppresses glucagon, which raises sugar. And importantly, it slows down how fast the stomach empties.
Slows stomach emptying. Does that help with weight?
Big time. That slowing effect, plus effects on appetite centers in the brain, often leads to significant weight loss. They're also very effective at lowering A1C. And crucially, large trials have shown that several drugs in this class reduced major adverse cardiovascular events, MAC, heart attacks, strokes, CV death.
So A1C lowering, weight loss, and heart protection. Sounds great. Any downsides?
The main side effects are gastrointestinal nausea, vomiting, diarrhea, especially when starting or increasing the dose, can be significant for some people.
Right.
There's also a small risk of pancreatitis and a contraindication if there's a personal or family history of medullary thyroid cancer or MEN2 syndrome, though that's rare.
Okay. And the other class, SGLT2 inhibitors, empagliflozin, canagliflozin.
These work totally differently. They block a transporter called SGLT2 in the kidneys, which normally reabsorbs glucose back into the blood. By blocking it, they make you literally pee out excess glucose.
So they lower sugar by wasting it in the urine.
Exactly. This leads to A1C reduction, some modest weight loss from losing calories of glucose, and a slight lowering of blood pressure, too.
And their big claim to fame is?
Incredible heart and kidney protection. Trials have shown powerful reductions in hospitalization for heart failure, even in people without diabetes, and significant slowing of kidney disease progression. They are truly cardiorenal protective agents.
Wow. Downsides for SGLT2s.
Because you're putting sugar in the urine, the main side effect is an increased risk of genital yeast infections. Also, urinary tract infections, though less common, dehydration can be a concern. And the most serious, though rare risk is euglycemic DKA.
Euglycemic DKA. Ketoacidosis without super high sugar.
Right. The SGLT2 inhibitor keeps the blood sugar from going sky high. Maybe it's only 200, 250. But the underlying metabolic process shifts towards ketone production, especially during illness, surgery, or fasting. Clinicians need to be aware of this possibility.
So for T2DM with ASCVD or even just high risk, GLP-1s or SGLT2s are now strongly preferred after metformin, which means some older drugs are less favored.
Definitely. We try to avoid agents that don't offer these extra benefits, or worse, might add risk. Sulfonylureas, for example, cause weight gain and have a high risk of hypoglycemia with no proven CV benefit.
And TZDs, pioglitazone.
Thiazolidinediones, or TZDs, also cause weight gain and critically fluid retention and peripheral edema. This significantly worsens the risk of heart failure, so they're generally contraindicated in patients with symptomatic heart failure and used cautiously otherwise, especially if ASCVD is present. The focus has really shifted to drugs that protect the heart and kidneys while managing glucose.
Makes sense. Okay, let's quickly cover a few special situations. First, stress hyperglycemia. This isn't really diabetes, is it?
Not in the chronic sense, no. Stress hyperglycemia is when someone without diabetes gets temporarily high blood sugar, maybe in the 140 to 180 range, sometimes a bit higher during a severe acute illness. Think sepsis, major trauma, big surgery. Their HbA1c would be normal.
What causes that spike?
Few stress hormones. Cortisol, Catecholamines, like adrenaline. They flood the system and tell the liver to pump out glucose, breaking down glycogen stores and making new glucose. It's the body trying to ensure fuel supply during a crisis.
How do we manage it? Do we treat it like diabetes?
Not usually as aggressively. If it's mild and the patient's stable, we might just monitor. If it's persistently high, say over 180 or 200, we might use some short-acting insulin. But here's the key difference. The target range is higher.
We don't aim for normal glucose.
No. We typically aim for a range of 140 to 180 milli-GDL in critically ill patients. Trying to push it lower, aiming for strict normal glycemia like below 110, has been shown in studies to increase the risk of dangerous iatrogenic hypoglycemia, which is linked to worse outcomes in the ICU.
So a bit higher is safer in that acute stress setting.
Exactly. Safety first, avoid the lows.
Okay. Next, type 2 diabetes in kids, in adolescents. This is becoming more common, sadly. How does it look different from type 1 in that age group?
It's usually a very different presentation. Unlike the often abrupt ketoacidotic onset of T1DM in lean kids, T2DM in adolescents typically presents more gradually in kids who are significantly overweight or obese, BMI usually above the 95th percentile. There's almost always a strong family history of T2DM.
And that skin finding you mentioned.
Acanthosis nigricans. That velvety dark hyperpigmentation, usually on the neck, under the arms, in skin folds. It's a major physical sign of insulin resistance. The underlying issue is that insulin resistance, often exacerbated by puberty hormones like growth hormone, eventually overwhelms the pancreas's ability to compensate.
And treatment starts with?
Metformin is still the first-line drug, along with intensive lifestyle changes, but often T2DM progresses faster in adolescents than in adults, and many require insulin or other agents relatively early on due to faster beta cell burnout.
Right, Kate. Diabetic gastroparesis, delayed stomach emptying. What causes that?
It's another complication of long-standing diabetes, specifically diabetic autonomic neuropathy damaging the vagus nerve, which controls stomach muscle contractions. The stomach just doesn't empty properly.
What does that feel like for the patient? It sounds miserable.
It is. Chronic nausea, vomiting, sometimes food eaten hours or even a day before feeling incredibly full after just a few bites, early satiety, bloating, abdominal pain, and it wreaks havoc on blood sugar control.
Because food absorption is totally unpredictable.
Completely erratic. If you take your mealtime insulin when you eat, but the food sits in your stomach for hours, your insulin peaks too early, causing hypoglycemia. Then, hours later, when the food finally dumps into the intestine, your sugar skyrockets because the insulin is gone. It makes glucose management a nightmare.
How's it diagnosed and treated initially?
Diagnosis involves ruling out a physical blockage, often with an endoscopy. Then, the gold standard is a gastric emptying study. You eat a meal tagged with a radioactive tracer, and scans track how long it takes to leave the stomach. First-line treatment is often metoclopramide, a prokinetic drug that helps stimulate stomach contractions and also has anti-nausea effects, though we have to watch for tardive dyskinesia, a movement disorder, with long-term use.
Okay, final special context. Infants of diabetic mothers, IDMs, what's the immediate risk right after birth?
Neonatal hypoglycemia. Severe low blood sugar right after delivery.
Why does that happen?
It's all about the environment the baby was in during pregnancy. If the mother has high blood sugar, hyperglycemia, the fetus is exposed to that high sugar too. The baby's pancreas responds by beefing up its insulin production. The beta cells actually multiply, called hyperplasia, and churns out tons of fetal insulin.
So the baby's making extra insulin to handle the mom's high sugar.
Exactly. Then, the moment the baby is born and the umbilical cord is clamped, that constant supply of glucose from the mother is suddenly cut off.
But the baby's pancreas is still in overdrive.
Still pumping out high levels of insulin, no incoming glucose supply. The baby's blood sugar crashes rapidly. These babies are also often large for gestational age, macrosomic, which carries its own risks.
So checking their sugar is mandatory.
Absolutely mandatory shortly after birth. And the immediate intervention is feeding.
Get glucose into them quickly.
Yes. Early and frequent feeding, breast milk or formula, to provide that glucose substrate and counteract the baby's temporary hyperinsulinism. This prevents potential brain damage from prolonged hypoglycemia.
Okay, we have covered a massive amount of ground today. An incredible deep dive, really, from DKA resuscitation to chronic T2DM drug choices.
We really hit the key points, I think. That fluid-first approach in DKA-HHS, the absolute vigilance needed for potassium, the critical role of blood pressure control for kidney protection, and this big shift towards drugs like GLP-1s and SGLT2s for their added heart and kidney benefits in type 2.
And it hammered home that management has to be so individualized, doesn't it? What an athlete with type 1 needs for exercise is worlds apart from managing an older person with type 2 and heart failure.
Completely. You have to tailor the therapy to the specific person, their risks, their lifestyle, their comorbidities.
Which leads us perfectly into the final thought we want to leave with you, the listener. We talk about hypoglycemia unawareness, HAF, and that behavioral avoidance driven by the intense fear of lows.
Right. That fear is powerful. It makes people actively run their sugars higher, undermining long-term control because the body's own warning system has failed them. The fear comes from the loss of those physical warning signs.
So, if the problem is fear stemming from lost physiological warnings, how might technology change that equation?
Well, think about continuous glucose monitoring systems, CGMs. They give you real-time glucose readings, trend arrows showing where your sugar is heading, alarms for predicted lows. It's like an external warning system.
Replacing the lost internal one.
Exactly. So here's the thought to explore. How might widespread CGM use fundamentally change the psychological experience for people with T1DM, especially those with HAF or intense hypoglycemia fear? If the CGM provides that objective early warning, taking away the terrifying surprise element of a severe low.
Does it directly combat the fear?
Could it? Could having that data, that predictive power, reduce the fear enough to allow patients to regain confidence, manage their insulin more appropriately, and maybe achieve safer, tighter long-term control again? It's about technology potentially overcoming a deep-seated psychological barrier rooted in physiology. Does data conquer fear in this context? Something to really mull over.
That's a fascinating intersection of technology, psychology, and physiology. A perfect place to wrap up. Thank you so much for walking us through all of this today.
It was my pleasure. Really important topics.
We'll catch you next time for the next deep dive.